I want to welcome you to this virtual event discussing racism as a public health crisis. I hope that you're all staying safe and well wherever in the world that you're tuning in from. We greatly appreciate you being here with us today. With the help of Green Templeton College, my classmate Imogen Malpas and I have put together this discussion to hopefully keep the momentum moving during these times of turbulence and change that we're seeing in many communities around the world. And as we're currently seeing with COVID-19, people of color disproportionately suffer from poor health outcomes in ways that have systemic and institutional roots. And it's critical that as a global community, and especially those who are in or considering going into healthcare, that we not only recognize these issues, but also channel this knowledge into action and allyship. And as someone from the United States myself, I've experienced how racial awareness has been galvanized by the recent murders of George Floyd, Breonna Taylor, and Ahmaud Arbery. And it is important that we are willing to listen as much as we speak and to strive towards positive change in any capacity that we're able to. And so with this event today, we really hope to center and elevate voices who have each made a profound impact in the public health sphere in order to discuss the implications of racism as a health crisis. And I want to thank these incredible speakers for being with us today, as well as our discussion chair, Dr. Noon Altijani, who is also a fellow member of Green Templeton. And I'd also like to give a special thanks to the Green Templeton administration for supporting this event and graciously lending us their time and the resources to make it a reality. So just to give a brief outline of what will be happening today, each of the four speakers will present for roughly 10 minutes, and then we'll have time for questions in the later half of the event. We encourage you to send questions by messaging the Q&A using the chat function at the bottom of the screen. And we understand that people may have different comfort levels with the topic today, so just to reassure everyone, the questions will be anonymously directed to the speakers by our chair, unless you indicate a preference otherwise. So please do send those in. We hopefully will, with time permitting, we can get through most, if not all, of the questions. And we also request that you please keep your videos off for the duration of the talk. So on behalf of Green Templeton, I want to thank you all for joining us today in this meaningful discussion. I'll now go ahead and turn it over to Noon, our session chair, who will introduce our speakers.
Thank you, sir, for the introduction, and thank you for all the speakers here today and for GTC for organizing. Also, thank you for everybody who's attending here, who's attending the session today. Declaring racism as a public health crisis is by no means a new thing. It is important for it to be acknowledged and to be widely recognized. Racism is fundamentally a social determinant of health, and it's very linked to the other social determinants of health, such as education, occupation, neighborhood. This is very important because data from different parts of the world, such as the UK, the US, have consistently shown that there are differences in health status as shown by health indicators affecting BAME population. For example, maternal mortality, an area where I've worked on for the past 3 years, is an area of very high inequalities, and these disparities by race or ethnicity are consistent in the West, where racism is rooted in white supremacy, but it's also prevalent elsewhere, such as in India with the caste system, and then in my native of Sudan with differences between Arab and African population. In addition to that, there are also differences in access to healthcare, the use and quality of, access to healthcare, use of, and the quality of healthcare. An important step to do is this, to stand up for these issues and for healthcare education, for medical education to do better. And one way this can be done is through medical education and training of health providers. Our first speaker today is Professor Monica Vela, and she's Professor of Medicine and Associate Dean of Multicultural Affairs at the University of Chicago, Pritzker School of Medicine. Within Pritzker School of Medicine curriculum, Dr. Vela has piloted an innovative course on health disparities, one of the few in the nation. Her research involves medical education on health disparities, care of patients population with limited English proficiency, and increasing diversity within medical profession. She maintains a clinical practice in primary health care and mentors junior faculty whose research addresses health disparity in Chicago's South Side. Thank you so much, Professor Vela, for agreeing to talk today, and over to you.
Thank you. I very much appreciate this opportunity. I think I should probably let you know that I came to this area of expertise because of my own lived experience in the United States. I was actually one of 2 people of color in my medical school class, and very much witnessed and lived what I'm about to teach you or talk to you about here in the US regarding medical education. I'm going to share my screen and pull up a set of slides. I'm going to apologize for the brevity of the slides. I actually teach on these issues over the course of 8 to 10 weeks for our first year medical students, and then continue teaching throughout the rest of the 4 years that they are with us at the Pritzker School of Medicine. So this is quite abbreviated. I want to talk to you about racism in our medical profession and also in medical education. Let's see. I'm going to talk about Abraham Flexner and the Flexner Report, the role of the American Medical Association, and how medical education is currently failing our students and our patients, and why we need to demand change. Abraham Flexner was a gentleman who was tasked with surveying all of the US medical schools in 1910. He came up with guidelines for reforming as well as standardizing medical education at that time. Truly, throughout my medical education, all I heard was how wonderful this report was and how grateful we should be to Abraham Flexner for his reforms. What I never heard about was chapters 13 and 14, which are easily accessible now on the web. Chapter 13 covered women's medical education, and chapter 14 was on Negro medical education. At the time that Flexner went around the United States, there were medical schools for white men, there were medical schools for white women, and there were medical schools for Black people. This is what he said about women's medical education. He found that there were no good reasons to keep women segregated from men when learning about medicine. He thought that women should be unified with men in an all-school basis, and recommended the closure of all women's medical colleges. No such luck for Negro medical education. He maintained that the practice of the Negro physician should be limited to his own race. So Black physicians should only care for Black patients, and Black patients should only be cared for by Black physicians. He also stated that Black physicians should actually be trained as sanitarians, which was the term for public health officials, not as physicians. And he also stated that the reason for this was that what was plaguing the Black community was really syphilis and tuberculosis, both of which could be dealt through public health measures, and there was really no need for physicians. He recommended the closure of most African-American medical schools, except for Howard and Meharry, though admittedly they would be unequal to the need. Knowing that there would not be enough African-American physicians to care for our Black populations, he still recommended closure of all but 2 of our schools. And you'll see here on a map of the eastern and southeastern portion of the United States where these 2 schools were located that were deemed good enough to be kept open, where the other schools were to be closed, and just how inadequate the service would be for Black people across the United States with only 2 such schools open and training physicians to care for them. You should also know that at this time, Black people were not able to be admitted to any white hospitals. And in fact, there were no hospitals for Black patients in the US. at that time. And so the care of Black patients was wholly inadequate. Added to this was the racism and discrimination of the American Medical Association. The American Medical Association in the United States is an incredibly powerful institution. It does quite a bit of lobbying in our governmental offices and sets the stage for policies and procedures for physicians. I myself have never become a member of the American Medical Association, and I will tell you why. So this is a summary of events that occurred in 1870, after our Civil War, after the presumed abolishment of slavery. The AMA decided to exclude the one integrated delegation in the United States, and in that year also admitted 2 white delegations, tabled a proposed non-discrimination policy, and absolved its own self of the charge of racism, fully recognizing the implications of these actions. By 1874, after being lobbied repeatedly to end its discriminatory practices, the AMA decided what a lot of our federal institutions often decide when it comes to complicated decisions. It turned the decisions over to each of the states and allowed each of the states to decide whether to integrate their chapters or not. Since most state and local societies were racially exclusive, African American physicians were again excluded from the AMA. Why is this such an issue? Well, the American Medical Association Society meetings was where all of the new innovations were presented. But in addition, it was also important to be part of the AMA if you wanted to have hospital privileges, if you wanted to be able to admit physicians to a hospital or to practice in a hospital, you had to be a member of the American Medical Association. In addition, because hospitals were where you trained for specialty training, African American physicians were exclusively barred from not only hospital privileges, but also barred from training to specialty training. Because of this, by 1931, there were only 2 African American specialists in all of the United States. Out of 25,000 specialists, only 2 were African American. One of them was Dr. Daniel Hale Williams, a cardiothoracic surgeon, and the first surgeon to successfully complete open heart surgery. This always makes me pause because I wonder what we lost. All of the brilliant African-American minds and what they could have contributed to medical advancement if these racial bars were not in place. So if one of the 2 specialists contributed so significantly to our medical advancement, imagine what we missed out on. Dr. Williams also went on in the 1930s to establish one of the first African-American hospitals. It happened to be here in Chicago where I live. It was called Provident Hospital. It was successful for many, many years before facing financial ruin at the hands of other local hospitals who did not want it to succeed. The AMA went on to discriminate both at state and local society levels well into the 1960s. Despite repeated attempts to change their discriminatory policies, the AMA was able to rebuff each of these attempts, and they're well documented. It was not until 1964, with the passage of the Civil Rights Act here, that Medicare forced the desegregation of every hospital in America, literally overnight. One of the most famous hospitals, Grady Hospital in the South, had 2 towers. And one tower was dedicated to white patients and the other tower was dedicated to Black patients. And in the middle of the night, Black patients were moved from one tower to the other in order that the hospital not miss out in any way of its Medicare payments. So this was financially driven. It was only then that the AMA voted to amend their constitution and bylaws and give the Judicial Council authority to investigate allegations of discrimination and expel any state or local societies found guilty of racial discrimination in 1968. And even then, it was not until 2008 that the American Medical Association actually published an apology. The reason this came about was that you'll see the list of authors there. The final author, Dr. Matthew Winia, was an ethicist working at the AMA in one of its oldest buildings, entered the vault and found all of the documentation and decided to publish the history of the AMA and the exclusion of African American physicians by the AMA. And so in 2008, an apology was published. I maintain that apologies are extremely important, that they should be public when made by these institutions, and that they should be paired with a pledge to change and amend and support opportunities for everyone to flourish. And by the way, the AMA currently has its first African American president. So I'm considering joining. So as my good friend, Dr. Scott Cook says, let's not spend all of our time reviewing racist practices in the past. It will keep us from acknowledging the racism in our present. And so I'm going to talk to you about why diversity, inclusion, and equity matter present day. I'll tell you about the case of cystic fibrosis and sickle cell disease and what's happened with these two diseases here in the United States. For those of you who may not know, cystic fibrosis and sickle cell disease are autosomal recessive genetic disorders that strike very different groups of people. Cystic fibrosis is most commonly seen in patients who are white, and sickle cell disease is seen in patients from Mediterranean areas, predominantly in the US African American populations. Two very different groups of people, not only because of their skin color, but because of the allocation of resources to these two groups of people here in the US. This is a graph showing the number of federal requests for applications funded for sickle cell disease exploration and cystic fibrosis from 1975 to 2004. And what you'll see here is that the number of research grants, program projects, and centers dedicated to the study of cystic fibrosis far outnumber the number of research grants, program projects, and centers dedicated to the study of sickle cell disease. This is despite the fact that in the United States, there are about 80,000 people with sickle cell disease and about 30,000 people with cystic fibrosis. You'll note the difference in the NIH funding for the study of these diseases. You'll note the difference in the private philanthropic support for each of these diseases, and ultimately that the total support per person affected with this disease is significantly different down in this lower row for people with sickle cell disease and with people with cystic fibrosis. And you may be wondering to yourself, is the NIH in the US so racist that it's handing out so much more money for the study of cystic fibrosis? I would contend that one of the reasons we see a difference in the number of grant funding going from one disease to the other is, number one, because only 2% of researchers at the NIH are African American. 2%. And this stems from our history, but also from our present. The second reason is that for a number of reasons, many of them racist in nature. Our people of color in their oppression have received fewer resources to thrive, to succeed, and to flourish in the United States. And so you'll see a difference in the philanthropic support that communities are able to donate to the study of these diseases. And very often when the NIH grants to researchers, they're looking for success in research. If you've already received funding, significant funding, to make progress in your research from a private source, you're much more likely to be further along in your research. You're much more likely to be successful, and you're much more likely to get that NIH grant, right? So this is a number of factors coming together to advance one group and not the other. In addition, I would tell you that our medical education here is failing our students and our patients. I can say that because of what we choose to teach and what we choose not to teach, right? It's both things. As of 2016, 40% of first and second year medical students endorsed the belief that Black people's skin is thicker than white people's skin, and that Black people feel pain differently than white people. Among physicians surveyed regarding the pain management of patients with sickle cell disease, 53% of our emergency department physicians believed that more than 20% of patients with sickle cell disease are addicted to opioids, compared with 23% of hematologists. Why the difference? Because our emergency department physicians do not develop relationships with patients that they see. They are much more likely to develop bias about the patients that they see because they're asked to work very quickly and in settings where bias is likely to set root. Hematologists develop relationships with their patients over time and are able to reduce their bias of these patients. But they're still inaccurate because it is actually less than 10% of patients with sickle cell disease who develop addiction to opioids. And that is no different than any other patient who suffers from chronic pain and is treated with opioids in the United States. A lot of bias to reduce here, but when we fail to teach on it at medical schools, we actually promote it at medical schools. And so there's a lot of distrust amongst our patients who are Black, Indigenous, and people of color. And they have good reason to distrust the medical profession. There's plenty of both historic and contemporary reasons for this distrust, and we see it play out now with COVID. To improve our outcomes and reduce disparities, we need to ensure our integrity, and physicians must step up to build trust. It is really on the medical profession to rebuild the trust that we have reached over hundreds of years. And so I would state that we need to radically alter medical education. We need to start at the very beginning and stop teaching our students to view race as biologic, but actually as a social construct. We need to end the use of race in algorithms, which is something that my hospital is struggling right now with. We are trying to end the use of race in our calculation of renal function. We need to stop teaching on disparities and inequities without first teaching on racism as a social determinant, and make sure that we never discuss disparities and inequities without teaching first on social determinants. We need to also acknowledge that all education is political. When we choose not to teach about skin color, when we choose not to teach about our history, when we choose not to teach why we have race-based calculations and how so many of those calculations came about as a way to justify slavery, and we're still using them. We are choosing to be political, and we are choosing to be politically incorrect. We need to change our bias-based admissions practices. We still struggle here in the US with the number of physicians who are actually people of color. Our numbers are very low. We need to start teaching on equity and advocacy, on the social contract, on the ethics of distributive justice. I've actually gone across the country to teach on these issues and to help medical schools integrate this type of teaching into the 4 years of their curriculum. And what I am often told is, number one, we have no one who can teach that because that should be taught by people of color, and we don't have enough of them. And number two, there's not enough time in the curriculum to integrate new curriculum, which automatically speaks to me on how unimportant this is to our leadership. We need to start teaching practices that promote not only the absence of disease, but the promotion of health and well-being so that everyone has the opportunity to flourish. Thank you.
I think it's always very shocking, but also not shocking to get to see and know these figures and data. I think you've also touched on a very important point on how these historic backgrounds are important, and it really helps us in understanding the roots of structural racism in our health system, and you've referenced COVID. I think that truly the current pandemic has exposed and exacerbated the systemic racism and injustices that are present in many countries. My mind goes to a quote by Professor Ibrahim Kendi when he said that this is a racial pandemic within a viral one, within the viral pandemic. Our next speaker, Dr. Danso, will speak on the structural racism in the NHS and the increased COVID-19 death rates for the BAME individuals. Dr. Danso is a GP in London. She's also a board member of the Ghanaian Doctors and Dentists Association in the UK and is a resident doctor on GN Radio UK. Her work on promoting health awareness and shining a light on medical discrimination on her social media platform, The Clinic Diary, recently has led her to receiving the Health and Wellbeing Advocate 2019 award at the National BAME Health and Social Care Awards. Over to you, Dr. Adwoa Danso.
Hi, thank you, and thank you, Dr. Monica Vela. I know it's incredibly difficult to organise something like this at this time, but it's so important. So I'm really honoured to have been invited to be speaking to you all today. So a little bit about me. I am a GP. I'm working in London. I'm also a very proud Ghanaian as well. And this topic of race equality is something that I'm really passionate about. Again, I'm really honoured to be speaking to you. So I think the first thing I would like to say is that to be able to understand more about racism with the NHS and more importantly, dismantle it, we need to really understand and accept that it exists. And I think that's often really difficult as healthcare professionals to acknowledge, but I think that's the first step. And also to have a better understanding, we only need to look at recent events to see what racism looks like within the NHS. The coronavirus pandemic has shone a light on some of the health inequalities and the existing issues that are within the NHS. We saw that here in the UK, 63% of medical workers that died were a Black, Asian or minority ethnic group. And to put that into some sort of context, 20% of the NHS is of Black, Asian or minority ethnic group origin. So completely disproportionate. Very early on, there were a lot of factors that were being sort of bounced around as to why this was happening. Some of those included, socioeconomic factors, overcrowded homes, poverty, which we know can be linked to poorer clinical outcomes. We also have to mention as well that comorbidities, so conditions such as obesity, hypertension, diabetes, all are more common within these groups. But there are more serious factors. We know that Black, Asian, minority ethnic group individuals within the NHS are less likely to be promoted than their white counterparts. And this could affect pay, for example. So in order to make the equivalent amount of money, you may have to work longer hours. It may be that you have to undertake less desirable shifts in order to make ends meet. We also know that within this group, individuals are twice as likely less to complain about workplace safety. And reasons for this could be, fear of being disciplined or sanctioned. So just to kind of put this into a bit more perspective. So imagine, I'm going to say Ghanaian because I'm Ghanaian. So imagine we have a Ghanaian nurse who is working during the pandemic, and she's not just supporting her family, her immediate family who live with her here, but she may also be supporting her family back home in Ghana. She may be taking up extra shifts. Now, the question is, would she feel comfortable enough to speak about PPE or the lack of PPE? And I think that's something that we all have to kind of understand. It's quite easy for us to say, well, why would you work in situations like that? But it's a challenge to speak out. And we know that bullying and harassment are unfortunately relatively high within this group. Now, as people were sort of talking about factors and reasons why, it seemed very early on that lower towards the list of factors was racism. But we have to understand, and we now know, that institutional racism is a factor in poor outcome. We have to realise also, our symptoms being dismissed more than others. We've heard about pain perception as well. In some communities, there's also a distrust of the health system. It was only a few months ago that we had French doctors on national TV state that they wanted to test coronavirus vaccines on Africans, which went a long way to cement already unsavoury feelings towards healthcare and, again, the NHS. And that kind of perpetuated some circulations of myths about what coronavirus is and was. There were myths such as 5G, whether that was associated with coronavirus. Was it man-made? Was it population control to get rid of Black people? Was it a way of introducing compulsory vaccinations? I think if there's anything that we take away, or anything that you take away from what I speak about today, is the the terminology that we use. And BAME. It's a term that I am not fond of, and I will come on to explain a little bit why. So coronavirus showed that BAME individuals were more at risk. But if we actually looked at the evidence and we looked at the details, Black Africans were at the highest risk. But again, it's not just coronavirus. This is not new. As I've said, it's shone a light on existing issues that have always been there. The Embrace study, which looked at the mortality in women during childbirth, showed again that Black, Asian, minority ethnic groups are again more at risk of, women are more at risk of dying during childbirth. But if you look at the statistics, Black women are 5 times more likely to die in childbirth, Asian women twice as likely. So yes, serious risks and serious statistics, but still quite different. Also, within this group, the genetics varies widely. And when we say BAME, I sometimes feel that we're essentially saying white versus non-white, or normal versus abnormal, standard versus anomaly. And that's how it's perceived. And we know that the treatments and conclusions can vary. My local CCG produced a report on CCG is essentially an organisation that regulates the general practices within a certain area. And they produced a workforce race equality standard, which showed that of their workforce, the people that worked at this organisation, 33% of the workforce were of BAME, which was actually 5 people. which was apparently stated as an overrepresentation of the local area, which had a population of 12%. But the question I have, as somebody who wants to have a seat at the proverbial table, how many of those were Black? What is the likelihood of somebody who looks like me having a seat at the table at this kind of organisation? So sometimes we have to look at this terminology and see what else we can use that's more appropriate, rather than placing all these various ethnicities together. I'd just like to share with you an example of racism that I have experienced during my medical career. I do apologise if you have heard this example before, but I think it's important to explain just what it's like to be a medical professional experiencing racism, and it's not just a one-off. During my junior doctor training, I was attached at a general practice surgery, and the teaching session was on drug and alcohol misuse. So in attendance were 2 other white trainee doctors, and the topic was, again, as I said, drug and alcohol misuse. The GP partner moved towards me and asked me, Adwoa, what do you think about cannabis misuse? Is that something that occurs quite frequently within the Negro population? Is that something that you and your family partake in? I was horrified. I was stunned. I was silent. I didn't say anything. Being the person I am now, I wish I had said more. And if that situation occurred now, I certainly would. But more stunningly, I wished my counterparts who were there said something, but they stayed silent. I'd like to work in an NHS or where everybody can challenge racism, and it's not just up to Black medics and healthcare workers to be seen and heard, but actually for our colleagues to understand the unique hardships and challenges that we face and speak out as well. As someone who has experienced racism through medical school, through school, outside of work, I can feel fatigued. I can feel frustrated. So I think it's important that that is kept in mind. And as I said, it's not just down to me. In an organisation, the NHS, where we are having to make a petition for skin conditions on Black and brown skin to be included in teaching material at medical school, we just have to do more. In an organisation where 1 in 4 Black women experience or witness racial harassment or bullying from managers, we have to do more. In an organisation where Black doctors are more likely to face disciplinary tribunals than white colleagues, we have to do more. In an organisation where UK educated Black trainee GPs fail their final exams at a significantly higher rate than the white trainee GPs, we just have to do more. But what does more look like? We need allies within the NHS. I think we also have to understand our patients and our colleagues, understanding that anger and frustration can be from previous experiences, can be related to negative experiences, but channeling that to achieve something more positive. I also want to say that it's all our responsibility to do the work, and you have to be actively anti-racist. You can't be passively anti-racist. It's not enough to sit back. We have to all be active. And I think with situations, especially in recent times, it can feel quite comforting to talk about your own experiences, but I think it's important that we don't center narratives around yourself, and often the Black and brown experience is just not the same as well. As I said, this is a really long process. This is not just a moment in time, and we all have to work towards that common goal. Diversifying the workforce is incredibly important. In the large, big organisations, such as the British Medical Association, the Royal Colleges of Surgeons, GPs, racism can't go hand in hand with good leadership. The NHS needs good leaders. A A diverse workforce in which all members are valued is linked to patient care, and ultimately, patient care is a priority.
Thank you so much, Dr. Adwoa Danso, for your talk, and thank you for highlighting the need for a collective effort to challenge the structural racism in the NHS and in other healthcare settings. Our next speaker is Professor Helena Hansen, who's a joint appointed professor of anthropology and psychiatry at the New York University Grossman School of Medicine. She is one of the leaders of a national movement called Structural Competency, aimed at training clinical practitioners to address social determinants of health. She has conducted extensive research in community-based health movements and the ethnic marketing of pharmaceuticals, as well as the historical and contemporary political economic forces shaping the treatment and stigmatization of opioid addiction in the United States. Over to you, Professor Helena.
You're muted, Helena.
Can you hear me? Is that better?
Perfect. Yeah, great. Thank you.
Okay. And do you see my slides?
We need, yeah.
Okay. It's not on the first slide. Okay. So I was just saying that it's really a privilege to be in this kind of company. Really looking forward to the discussion because I've learned so much already. So I'm going to attempt to summarize some of my findings from my forthcoming book on the US white opioid crisis. And so I'm going to turn the lens a little bit onto whiteness and argue that whiteness is central to our commodified biotech and healthcare industries and the use of racial hierarchies to segment and open markets. It involves the mutual racialization of drugs and people. So we know, and this is where I left off on my slides, this is a slide signaling the US white opioid crisis. So we in the US have much more conversation right now about whiteness than we did prior to this article coming out just before the last presidential election that led to our current President Trump. So we know that illegal drugs in the US have long been linked to Black and brown people, but also drugs can be white. As in targeted to white people, they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. And so today I'm going to give you an analysis from my forthcoming book in terms of what I call technologies of whiteness, and that is social technologies of neuroscientific metaphors, policy and industry strategies that maintain racial boundaries around biomedical uses of opioids. So this scheme is informed by whiteness studies. And whiteness studies is an offshoot of critical race theory. It predicts that whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries, as in who counts as white and who doesn't. White race is unmarked as the assumed norm. It's rarely explicitly mentioned. In the US, that has changed a little bit since the 2015 article that I just showed. But still, whiteness is the assumed norm, and in public policies and in the media, race is usually mentioned when someone is not white. Whiteness is defined by its other, that is, white and Black or non-white are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for whites who've had access to personal doctors. And one of the images that I showed alludes to that in the 1940s to 50s. White privilege has its costs. So that is, not only do white consumers pay inflated prices for patented prescription opioids, they also pay with their lives in the form of overdose by lethal substances to which they have quote unquote privileged access. So the technologies of whiteness that I've identified are addiction neuroscience, new biotechnologies, regulation, and marketing. And I'll hop right in. The first one, it's the least visible technology of race making, is that of brain science. we have to place opioid development on the backdrop of President Bush the first's decade of the brain. So this was an era in which the National Institute on Drug Abuse was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. And in the process, NIDA renamed addiction as a chronic relapsing brain disease. The scientists involved in this movement had a social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition rooted in molecular action at neuroreceptors and not a problem of morality or choice. Brain images like this, by taking the subject and his or her trappings of gender, race, and class out of the picture, and by taking the offending organ, the brain, out of the body altogether, conveyed a universal condition, unmarked by social identity. What the scientists didn't anticipate was that the scientific universalism that they were alluding to, because it implied a standard white male subject, would help open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. So the next technology, whiteness, new biotechnologies, building on the neuroscientists' ideology of technological solutions to addiction, in 1996, Purdue Pharma got FDA approval for OxyContin as a quote unquote minimally addictive opioid pain reliever suitable for chronic management of moderate pain. This was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush. Drug marketers advised new opioid prescribers to direct OxyContin to quote unquote trustworthy patients, which in a national clinical workforce has been shown to suspect non-white patients of drug abuse. So this implied white patients, that this was a drug for white patients. And of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. So OxyContin users interested in a rush quickly learned to crush and snort or inject the oxycodone in each capsule. Another biotechnology developed specifically in response to the growing white suburban and rural prescription opioid epidemic is the opioid buprenorphine, which was legalized for maintenance treatment by prescription in private doctors' offices, unlike methadone, which is dispensed daily in highly regulated clinics. So in the 1990s, the National Institute on Drug Abuse subsidized buprenorphine's manufacturer, otherwise known commercially as Suboxone, with $23 million to test it for use in addiction treatment and sharply distinguished it from methadone. Lobbying Congress and the DEA, the Drug Enforcement Agency, to lower the abuse potential rating of Suboxone or buprenorphine to the same class as codeine cough syrup. So the third technology of whiteness is regulation. The Drug Addiction Treatment Act of 2000, which was passed by Congress in 2000 to enable certified physicians to prescribe Suboxone in the privacy of their own offices, really distinguished it from buprenorphine from methadone, which continues to be restricted to specialized clinics. In congressional debates leading to the passage of Data 2000, there's a clear emphasis on a quote unquote new kind of user, one that's young, suburban, and quote unquote not hardcore, that is implicitly white. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, which quote tends to be concentrated in urban areas and is a poor fit for the suburban spread of narcotic addiction. With this racially coded language in which suburban and new kind of addict referred to middle-class whites, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance treatment for opioid dependence. So this act, Data 2000, kept the restrictive methadone system intact and did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those with the resources to use it. So to give additional assurance to the DEA that buprenorphine would not spill over into illicit, implicitly black and brown markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course, which was required for doctors and other prescribers to provide buprenorphine. It was the first and only prescription drug in the US to come with such a requirement. And in a race and class stratified healthcare system like we have in the US, where access to general doctors is often limited to those who can pay, patented expensive technologies for private office delivery in themselves encode white race and middle class. Also, public sector doctors tell me that the certification requirement is a major barrier to making buprenorphine available to low-income people, as public clinics do not provide time or incentives to pursue certification, while prescribers in the private sector can charge fees of up to $1,000 for an initial visit for buprenorphine induction. So the shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private and white sector. The last technology, whiteness, ethnic marketing. In '96, the FDA accepted OxyContin's manufacturer's claim that it posed less than 1% risk of addiction, enabling Purdue, the manufacturer, to open an opioid market that had previously been restricted to those with severe acute pain like post-surgical cancer pain, and open a new, much larger market of patients with moderate chronic pain like lower back pain, hiring almost 700 drug reps who canvassed a call list of 100,000 physicians in the first few years. So the manufacturer targeted generalist doctors in white, suburban, and rural areas, serving patients that the public and our drug enforcement agency did not think of as at high risk of addiction or diversion to drug trade. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, with disproportionate uptake of OxyContin by prescribers in white, suburban, and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. So in a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latino drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. And after the government imposed restrictions on opioid prescribing, many of these suburbanites turned to heroin, leading to a whitening of the media coverage of heroin users who had long been portrayed as Black or brown. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. Manufacturer-sponsored web-based public service announcements featured white professionals and business owners on Suboxone or buprenorphine maintenance. So this same website that you're seeing features a link to a Suboxone prescriber locator service created by the Federal Substance Abuse and Mental Health Services Administration. Browsers enter their zip codes, of their residents, and they get a list of prescribers, buprenorphine or Suboxone prescribers, most of whom are in private practice. So these strategies created an exclusive yet lucrative segment of the market for Suboxone, otherwise known as buprenorphine, making it a blockbuster drug at over $1.5 billion a year in US sales by 2012, second only to OxyContin, which reported US sales of over $3 billion in that year. So just briefly in conclusion, racial capitalism is a primary driver of biotech industries in the US and beyond. And that is because new technologies are pitched to an exclusive, affluent white clientele that can pay for patented products. They open markets for new products that eventually trickle down to non-whites as patents expired. So this is a recurring pattern. 2, whiteness is a primary and unnamed driver of racial capitalism in biotech and healthcare. To understand structural racism, we have to attend to the technologies of whiteness themselves, not only the ways that Black and brown people are excluded or deprived. And then 3rd, racial capitalism in healthcare and biotech kills white people as well as non-whites. So not only do white consumers pay inflated prices for prescription opioids, they pay with their lives in the form of overdose by lethal substances to which they have this privileged access. And if our foundation for healthcare is profit motive rather than public health principles or common good, any market segment can be sacrificed for short-term gain. All are vulnerable in the end. So just look at the current COVID containment failures in the US based on profit motives and racial capitalism, hoarding of supplies, and the feeling among whites that it's possible to insulate themselves from Black and brown people who suffered first in the epidemic. So I have more to say about what we should do about this, but I'm going to hold it for the discussion. Thank you.
Thank you, Professor Hansen, for your presentation. Where we are now going into our last speaker, but before that, I would just like to remind you that after the 4th presentation, we'll have a Q&A session. So feel free to send your questions to the on the chat box to the Q&A in the participants. Our last speaker is Mr. Adwoa Adeyemi, who's the director of the Chatham House African Public Health Leaders Fellowship and is founder and managing director of Global Health Jobs. It's an international health jobs platform that brings hundreds of overseas health professionals to the UK. He also sits on the executive committee of the NHS BME network and is member of the Davos World Economics Forum's Global Shapers community. Today, he will be talking about how to tackle structural racism from corporate activism perspectives and discussing the type of leadership that is needed to actually make changes in organization. Over to you, Mr. Ade.
Good afternoon, everyone. Thank you. I've got a presentation, so I'm just going to share my screen. This works. Can everyone see it and hear me? All good? I see Helena logged in. Brilliant, thank you. Well, thank you all for making the time, and thanks for that warm introduction, Noon. I don't speak in a capacity of Chatham House or the NHS England. It's certainly a personal capacity, so please don't say it's an official word from any of those organisations or you'll get me fired. But yeah, just to build on what other people are saying, I approach this thought from an interesting perspective where I thought initially, what are the kind of films, or are there many films about healthcare and the challenges in healthcare? And when I say films, I mean Hollywood films, because we do have episodic type productions, ER, Holby City, etc. But films that kind of have a beginning, a middle, and end that talk about a problem. And Contagion has obviously had increased views following coronavirus. And that started off a kind of chain of thinking about the problems of talking about race and racism in healthcare. I definitely picked up a lot of we in the conversation. I picked up a lot of, it is all our responsibility from many of the other speakers, which, isn't always a great hook and a great story to tell when you're trying to, talk about or display a challenging, complex information to a large number of people. And then the other thing that I thought about was actually, the concepts of good and evil and problems in our society, have changed from the clear hero character, personality. We now have complex characters.
News for 15 minutes.
Hello? Am I good to go? All right, so yeah, so, we had clear hero type characters of Luke Skywalker or Superman, but now we have really complex characters. Luke Skywalker now is a person who questions the Force. Superman is a person who has challenges with government. And even the historically challenging dark characters like Wolverine, Batman, even James Bond, are now even more problematic, and they're, dealing with other issues. So, the myths that we tell about our society are getting even more nuanced and challenging to talk about. The link here with racism in the NHS is that it's a very complex story to tell, and perhaps that's and this is where I'm coming at it. That's where I feel the leadership stumbles at its first hurdle, is in who is at fault here, who is the hero, who is the villain. And actually, are we comfortable talking about heroes and villains when it comes to healthcare, when we perceive, the public perception of doctors, nurses, healthcare physicians, all-time high across all professions, has always been. You look at many polls, they always reflect highly on the healthcare industry. So there's a kind of problematization of racism. How do we problematize racism? How do we talk about it? What's the narrative that we can then use to bring other people along and say, this is the challenge we're trying to deal with. Help us understand your role as an ally, as a bystander. What does that mean to be tackling the problem of racism in healthcare? Again, I think we all know this character, Dr. Harold Shipman, evil character, there is such an uncomfortability talking about evil people in healthcare settings, and racism is an evil. So an evil that's systemic. It's not focused on one person, which again is a easier story to tell when there's clearly a villain, when there's clearly a bad person that, you know, we then need to fight against. But, you know, this is, moving on, I'll give you an example of, to just flesh out what I'm trying to explain here. You can't see the detail here, but I've done a bit of a data mining exercise where I looked across NHS choices. So you can see, you'll have to take my word for it. I've looked at every single page on the NHS choices website where they list every definition, condition rather, and they have a picture that shows the condition. I think, as we've seen in other people's talk, there's a problem with, you know, the medical dictionary, medical lexicon, you know, pandering, referring to, you know, white conditions and not really being a service or something that can speak to black conditions. You look at all the pictures here, and this is every single picture. So these are the two slides that show you every single picture from every condition in NHS choices that has a picture that explains what the condition is. And as a black father, I've gone on the website when I'm trying to understand whether this rash on my black skin, on my daughter's black skin, is, you know, meningitis or not. And, you know, the health service doesn't necessarily work for someone like me. The story here about racism in the NHS, racism potentially in NHS choices, you know, who is responsible? There isn't a director at NHS choices or a designer at NHS choices you could point to and say, that's the problem there. That's that, you know, we need, you know, that's the person that needs to be addressed. That's the person that can fix it. And so there is a real, I think, problem about engaging others, engaging allies, engaging people that don't understand what the problem is, because there isn't a focused narrative, there isn't a focused person to kind of lead that conversation. There isn't a hero, there isn't a villain. A bit of a left field way of coming at it, but for me, I think this is something that you know, really challenges any kind of progressive movements on this. So, you know, in summary, it's about, particularly with a increased use of social media and, you know, reduced attention spans, is there, and this is the leadership challenge I throw to people in this arena, is there a way that we could, and I know it's a very complex emotive issue, but is there a way that we can package the stories we're trying to tell so that your man or woman on the street who doesn't necessarily believe that the most valued institution in Britain, the NHS, has a problem, can succinctly understand what it is? I take myself as a casual, you know, environmentalist supporter. The Extinction Rebellion thing I kind of understood, but it wasn't until Greta Thunberg stood up as a pointed person that, you know, someone like me who didn't really engage with that matter, and actually lots of my friends in East London who don't even know the first thing about recycling, could point to someone as, you know, someone to help tell the story, to help illuminate. And I think this is a big leadership challenge in this space, that it's quite a distributed way of responding to the problem with Black Lives Matter. There isn't a single person, and that has great benefits, that also has some disadvantages. So just the kind of food for thought here, just my random thinking, starting from Contagion to Heroes and Villains, was how do you tell the problem, or how do you tell the story rather, of the problem of racism in healthcare settings when it isn't pointed at one person, when there are many different, you know, parts in the system, people to, you know, help create solutions, as well as people who are blockers. You know, we each have individual stories. We heard from the doctor early on about her medical training, and you know, if you talk to any person of colour, they probably have at least 10 stories of either obvious or, you know, non-obvious racism or racial aggression or microaggression. So anyway, that's my kind of food for thought. Open to hear any questions or thoughts on that. Thank you. Noon, I think you're on mute.
Yes, thank you. Thank you, Mr. Addy, for the presentation. We now open the floor for questions. you can send your questions in the chat to the Q&A participant, and these questions will then be forwarded to me. We have a first question for all the panel, and the question is, can racism be quantified at an individual level or at a systemic level in healthcare?
Do you want to direct to one of the speakers?
Maybe we can we start with Dr. Danso as a primary healthcare provider?
Sorry, do you mind just repeating the question? Sorry, I didn't.
Sure. Can racism be quantified at an individual level or at a systemic level in healthcare?
I think that's quite difficult. I think racism is definitely a systemic problem. You know, that society is built on racism. Unfortunately, I know it's a difficult thing to hear, but it's true. I don't know whether it's able to be quantified, but that's pretty much my feeling. I don't think we can quantify it on an individual basis. It's definitely systemic.
Mm-hmm. And maybe just to build on that, what about in issues, for example, of mental health? Are there, for example, data here in the UK, or do you know of any that have been collected to show, for example, the effect of racism on mental health on maybe Black and other populations?
Yeah, I know that there have been studies done in the US. I don't know if any of my colleagues might be able to help me out on this, but I know that there have been studies that have shown that chronic stress has been associated with poorer outcomes within the Black community. So I don't know if, is it Dr. Helena, you would know a bit more about this at all, the specific study. I can't remember off the top of my head, but certainly there have been studies done in the US which does demonstrate that.
Yeah, I think you are absolutely right. And in fact, some of the comparative studies that have included both US and UK in their lens have lent credence to that. So I'm a psychiatrist as well as an anthropologist, and have long been following, for instance, the statistics on schizophrenia and Blackness.
Mm-hmm.
So many claims earlier was that people of African descent, sorry for the noise, people of African descent were somehow genetically predisposed, and that's the go-to explanation for racial differences. But international comparisons, for example, of schizophrenia, demonstrated that the social environment is incredibly important. So in the US, Black men are 4 to 8 times as likely as white men to be diagnosed with schizophrenia. The statistics are similar in the UK. If you go to West Africa or other parts of the world where racial identity has a different valence, those statistics look quite different. The same is actually true of physical health problems such as hypertension. So in the US, there's a lot of discourse about how Blacks must be predisposed genetically to hypertension and all of the conditions like cardiovascular and renal disease that go along with that. They have much higher rates of cardiovascular disease, kidney disease as a result of hypertension. Genetic cause has long been received lots of NIH funding as a possible explanation. But if you go to West Africa or Brazil, where of course racism exists, it has a different valence, the rates of hypertension are much lower. And in fact, in West Africa, they are lower than those of US whites. So those kinds of international and cross-site comparisons, I think, highlight how much the particular valence of racism, although, you know, racism is a worldwide phenomenon, it takes different forms and it's experienced differently on the ground depending on the context. So to answer that question about can you quantify racism, those kinds of international comparisons help to do that. I'm an ethnographer. I think that it's quite important not only to quantify, but to understand what you're quantifying and how you're labeling it, because many of these phenomena are not captured by our typical statistics. And, you know, in my argument about structural racism in biotech and healthcare, I had to do quite a bit of participant observation and in-depth interviewing and drawing on my own privileged observer position as an addiction psychiatrist to unravel the threads of how systemically these things take shape. So it's not just a matter of a racist encounter between doctor and patient, which is the way in the US often we like to think about it. And that leaves individual providers off the hook to think, I don't feel particularly racist. You know, I have Black friends, so I'm not a part of this. We need multiple methods to document how racism works as a system, how it's institutionalized, how it's invisibilized, how coded language, for example, not using the term white, but using the term suburban. In the US, there are many coded languages for race that help to hide its origins and help to hide how it works systemically. One of the authors that I cite very often is Michelle Alexander in The New Jim Crow, where she's writing about the origins of mass incarceration in the US. And, you know, in the US, Black men are 6 times as likely to be incarcerated as white men, with really enormous health consequences. So in tracking how that works, she also pays attention to legislation, federal legislation that led to this mass incarceration through drug war policies, where race is never mentioned. It's absolutely never mentioned, but it's conveyed very clearly in coded language who these laws are intended to target. And so that's why we can't rely only on the statistics that are already available, already gathered, and the labels that are already pre-formulated by people who are not necessarily attending to these issues, that are actually participating in invisibilizing how this system works. We have to use mixed methods and our eyes as critical scholars. And that's one thing that I've gotten so much from on this panel. My co-panelists have done a lot to unpack that language and the symbolism and the way that race is baked into the system in ways that are hard to recognize if you don't use that critical lens.
Thank you. The next question is directed to Professor Monica. The question reads, choosing to ignore race from algorithms as an effort to be unbiased might actually further perpetuate existing racism and biases subconsciously, especially if the majority in the field are white. Do you have thoughts on how to deal with this?
Can you repeat that one more time?
Sure. Choosing to ignore race from algorithms as an effort to be unbiased might actually further perpetuate existing racism and biases subconsciously, especially if the majority in the field are white. Do you have thoughts on how to deal with this?
Right. So it really depends on the algorithm that we're talking about. When we choose to use an algorithm to diagnose a disease, we should not include race, because race is not a biologic construct, right? And we're talking about a biological disease. On the flip side, we need to study racial groups in terms of outcomes and responses to therapies, because we need to understand where the racism is coming in to our therapies, into our health care and our healthcare delivery, and why these outcomes look so differently. So for an example, pulmonary function testing used to diagnose asthma, obstructive lung diseases, restrictive lung diseases, need not incorporate race, but many of our hospitals still use race as an algorithm in that testing. Where did this come from? Pulmonary function testing actually originated as a mechanism to justify slavery in this country, the outcome of which initial studies demonstrated that Black people had higher or larger lung function capacity, and so were better suited to work in the fields. Because of those early pulmonary function testing algorithms, we have continued to use race in that algorithm for years and years. When we've now, because we're paying attention to these issues, demonstrated that it doesn't belong in the algorithm, that it is of no benefit to anyone, and in fact may underdiagnose patients, in particular people of color. We continue to use race quite often in our calculation of renal function. Why do we do this? Because of a very early study that did include a diversity of people and determined that Black people have a higher muscle mass, produce more creatinine, and that we were underestimating their renal function. Now, when I say there was significant diversity in that study, I think it's about 6% of the participants of that study were Black, which totaled about 50 people. Because of those 50 people, we changed the way that we calculate creatinine function for the entire country. I work in a hospital where 70 to 80% of our patients are African American. What are we doing? We're actually lengthening the time of patients with significant renal disease. We're lengthening the amount of time it takes them to get to transplant. So actually we're harming them by using race in those calculations. So it's all in how we use it. Intent is not enough. We need to see where those good intentions get us in the end.
Thank you. The next question, which is on how can we get medical schools in the UK to teach how medical conditions present across different skin tones. And I think this has been spoken about by some of the different speakers today, how in dermatology, for example, conditions, and in medicine as a whole, this can present differently. You can start, Professor, if you don't mind.
Oh, this is for me. So I'll tell you, our students are quite powerful, and they actually have a larger voice than you might imagine. So with everything that's been happening here in the US, our Black students have organized and have presented both nationally and at each medical school a group of demands. Mm-hmm. And those demands include everything from form a committee to review all of our curriculum and look for opportunities to introduce material not only on disparities and inequities, but to improve the diagnoses of all of these issues amongst all populations, to review the use of race-based calculations, to introduce implicit bias training for all the faculty, because we're tired of doing it for you. And we're taking it very seriously. And we thought we were at Pritzker well ahead of the curve in terms of what we were doing, but clearly there's a lot more that needs to be done. The other thing that they've lobbied for is a real-time reporting mechanism for bias incidents. Something happens, they report it, they want a response, right? And I think this is incredibly important, and I'm happy that they are making these demands. I'm very pleased that they're pointing to our failures, and it is often that I'm very pleased when our accreditation institution fails us as an institution on particular markers, because for me, that's an opportunity to demand resources to make change happen. I think the time is now. I think the moment is now. I think our youth are leading, and I think we need to follow.
Mm-hmm. Thank you.
To second that, if I could just expand a little bit.
Yes.
I agree with all those recommendations, and also with the statement that trainees have very strong voices. Trainees are not yet embedded into the system of promotion and all of that faculty are. And I've seen how much progress trainees can make when they organize amongst themselves and make very specific demands and threaten to go public. In the US, there's actually a national organization of trainees that have begun ranking medical schools in terms of health justice and attention to health inequalities. And they gave very bad report cards to certain schools that have since then invested money and done a lot of work on faculty recruitment to address that kind of bad publicity. So I really agree that trainee voices are strong. They have to be organized, and they have to be willing to use publicity and go outside of the institution where necessary with that publicity. I also want to just mention that I am organizing with colleagues in national movement that we call structural competency. You mentioned it in my bio. The idea is to really operationalize structural racism, institutions, policies. What is the role of the clinician in addressing institutional practices and policies, not just the doctor-patient encounter? Because if we're truly serious about making an impact on patient outcomes and health equality, we have to address institutional policy level drivers of those outcomes. It doesn't just happen in the doctor-patient encounter. Doctor-patient encounter is quite important, but I think every single speaker that is on this panel has made a compelling case that that's not where all the action is. In fact, most of the action is outside of the doctor-patient encounter. But clinicians have a particularly important potential role in that, in framing certain policies, for example, as health policies. So the drug war in the US has been a tremendous driver of health inequalities in the US. Labeling it a policy that is destructive of health and addressing it as such has made a big difference. So we now have calls for reduction in prison populations and reform of law enforcement practices. And much of that came from really attending to the health consequences. And clinicians have a particular voice in doing that. They bring a particular symbolic capital. And then when it comes to institutions and community engagements, there are many ways, and this is a part of the structural competency framework, we as clinicians should be trained in how to collaborate with community organizations so that we structure our healthcare in ways that are responsive to community leadership and community needs. And that speaks to the trust issue that's come up in many of my co-panelists' discussions, building community trust. We also have to understand how our own healthcare institutions work, but also institutions like housing agencies, law enforcement, schools that have tremendous health impact on health outcomes. How can we collaborate with those kinds of agencies to address social determinants of health in our clinical care? So, so there are many different levels at which we as clinicians could be addressing structural racism. We don't have to confine ourselves to the doctor-patient encounter, but that's a particular weakness right now of clinical training. And I'm convinced that it's by design. In the US, that kind of institutional perspective has been separated off from clinical training and confined to schools of public health or elsewhere. Yeah. And I think that that is the individualism, the individual focus is something that's been a very powerful tool for preserving the racial hierarchy that we have. Because if we can only think in terms of the individual patient and blame any outcome on their individual beliefs and behaviors, we're never going to attend to the structural drivers of health inequalities. So that's my push for, in clinical training, attending to structural action.
The next question is also to you, Professor Helena. And in many medical schools, there are often extracurricular groups tailored to supporting and advocating for the Black, Indigenous, people of color community. To what extent do you think that intentionally dedicating time to storytelling in medical education by allowing marginalized students to share their experiences could help increase anti-racist allyship?
What a wonderful question. And of course, I agree with that as somebody whose main medium is narrative, because we as humans construct the world based on narrative, on stories. So back to the question of statistics, what kinds of stories do we make of those statistics and which stories lead to the collection of data for those statistics? So I think the stories of BIPOC people are incredibly important. They need to be privileged. The other advantage, I think, to centering the voices of BIPOC clinicians and trainees is that we disproportionately come into medicine with a critical perspective. We absolutely do. Our lived experience gives us a basis from which, an external perspective from which to critique the practice of medicine. We don't come in, on the whole, most of us, thinking everything should be just received at face value. Mm-hmm. And so we actually bring a set of analytic skills, just inherent analytic skills from our lived experience that our white colleagues desperately need. And that's something that our white colleagues are going to benefit from in the centering and privileging of our stories, because we're going to bring that kind of analysis, the structural institutional level of analysis, among other things, to the playing field.
Thank you.
Can I just jump in and say, I could not agree more. The benefits to diversity amongst medical students, amongst physicians are invaluable. Not only in terms of questioning the system and taking down processes that are racist, but on an individual level, the learning for advocacy and care of populations is tremendous. I will say that places an additional burden on students of color and physicians of color, which we here call the brown or black tax. It's an extra mile that you have to go, but the benefits are tremendous. We've actually established an identity and inclusion council to create civil discourse around these issues, and often create panels of students and physicians and professors across our institution to explore these very issues. And it has been an incredible wealth of information.
Thank you. The next question is directed to Adi. How do we get away from defensiveness in white or at times brown allies, especially in our powerful institutions, for example, in the NHS and in the Royal Colleges, to allow them to help tackle structural racism when at the heart of it, they are clearly benefiting from the current systems?
So if you're in an organization or corporation, then I think you can speak to your, and there's different terms here, diversity, inclusion, equality, diversity, inclusion agenda, which normally will sit in your HR or organizational development kind of directorates or teams, and ask them for, kind of cultural sensitivity, allyship training. There is performative allyship and then there's authentic allyship. And I think you would want some kind of structured program that really made it clear what the difference is and empowered both Black and ethnic minority, Asian and Southeast Asian colleagues and staff, and also white colleagues to understand what that is they could call out and actually move more towards the authentic allyship. And if there is performative allyship, which isn't, it's the virtual signaling for virtual signaling's sake rather than actually trying to be an ally or helping someone, then it empowers everyone to have an understanding about what the difference is and what kind of allyship people should be looking for. But I think you should be lobbying your HR directors to roll out those programs, to roll out those initiatives to upskill everyone and make sure everyone understands and is working towards authentic allyship in your organizations.
Thank you. The next question is for Dr. Adwoa. The person is would like you to explain a bit more about what you thought about the different terminology, the BAME terminology and the other terminology, other terminologies used to refer to people of color, and what alternatives are there? And I would also like to expand it for other panelists who would like to comment on that as well.
Yeah, I mean, I dislike the term BAME. I think, as I said earlier, I just think you are essentially grouping everybody together that's not white. And within that group, you have so many different ethnicities. So if we look at African people, within Africa, there are so many different countries with different ethnicities. So if you look at the genetics, even in a country, or let's say Ghana, Nigeria, the genetics will be slightly different. And so when we gain evidence and collect data, and you're grouping all of those ethnicities together, I mean, what do you do with those results? What does that mean for a Ghanaian person and an Indian person? Oh, it's sort of like a one size fits all, which I just think isn't what is helpful for medicine at all, really. I forgot what the last bit of the question was. Alternatives, that was right. So alternatives for what we could say. I mean, I always say this, like just say black, I think people find it really hard to say black, but it's okay. No one's going to be upset for you saying black. But I think even more importantly, I think we should actually individualize as much as possible, because that's more useful in terms of actually addressing people. I personally think even Afro-Caribbean, I don't think that's particularly helpful. Again, I'd rather someone say I'm African. So I think we have to kind of move away from that term, because it's just not, I don't think it's particularly helpful.
Thank you. Would any of the other speakers like to comment on that? Okay. The next question is also to you, Dr. Adwoa. What resources would you recommend for younger people to combat racial bias? And how can Black medical students deal with how implicit biases might affect medical school teachers' interactions with them?
Yeah, I think that's a really it's a really tricky one, and I've heard some of my colleagues on the panel speak about, you know, the power of the medical student, the power of the trainee. But I also have been a trainee. I have been a medical student. It's actually not so easy to be outspoken and drive initiatives, because really and truly, I mean, looking back at my own personal experience, I was trying to just keep my head above water without, you know, attracting too much attention. I don't want to be perceived negatively at all, and that's just from growing up and experiencing it. So you just try not to come across as too demanding or too confident. You just sort of sit in the middle. So it's easier, I think, said than actually done. But the great thing is we're having this discussion. The great thing is that there are organizations in place that are working towards improving standards, improving teaching of medical students as well. So, you know, as I said, I work really closely with my colleagues in the Ghanaian Doctors and Dentists Association, which are doing fantastic things for people within our community. There are other smaller organizations, one being Melanin Medics. I wish that Melanin Medics existed when I was a student, because they highlight lots of Black doctors and dentists who are doing fantastic things within the UK. And I think having such a powerful organisation of people that look just like you is important, particularly as a medical student and as a trainee.
Thank you. We're about to reach the end of the panel. I would like to ask other speakers if they have anything to say before we close off the questions.
Maybe just one comment based on Dr. Danso's very astute observations about how much of the way that racism works for different groups is washed away by an arbitrary lumping together of non-white. I think that we have to also be willing to teach and consider the complexities that Dr. Adeyemi was referencing. So on the one hand, these racial categories are not biological categories. They don't make any sense. If you look, for example, across the African continent at genetic variation there, it just doesn't make biological sense. However, they have social consequences. So they are absolutely real, and they have biological consequences. So the arrows of causation are different than what we're often taught. It's the racial categories that cause the biological outcomes in most cases. So with that awareness, we have to be able to take a hold of the complexity and make strategic alliances, because sometimes the similarities in the ways that different groups are experiencing disparate health outcomes, exclusions, and violence in the healthcare system, there are important parallels that really lend themselves to strategic alliances, and I don't think we should lose sight of that. On the other hand, racism is a system, and so its relative position within the system and age-old kind of tropes and strategies for grouping people and excluding people that count. I'll give you an example of how race can shift. Racialization is a process, and race is a position within a system. So drawing on the US opioid crisis, there's definitely been, as whites have been affected, a biomedicalization of addiction. So the answer is going to be medical treatment as opposed to incarceration because of the group that's perceived to be affected by opioids all of a sudden. But there are definitely areas in the US where criminalization, in addition to Black and brown neighborhoods, continues. In the predominantly white Appalachian area of the United States, there is continued high incarceration and continued high foster care placement for children of people who are identified as opioid users. And a lot of the language in local media used to describe people who are on opioids sounds precisely like the language used to describe Black and brown people in inner city areas. And so my sociology colleagues who work there say that poor whites in predominantly white areas are racialized because there aren't Black and brown people to other. They occupy a racial subject position that otherwise would be occupied by Black and brown people. So I just point this out because I think we need to be willing to embrace the complexity of race as a system and these subject positions to understand how it works as a system and how it draws very parallel patterns among groups that are genetically and phenotypically distinct from each other. And if we can take it on as a system, we also see natural roots to allegiances to work against the system as it harms so many different people.
Thank you so much.
Thank you.
I'd like to thank all of the speakers here today and the organizers. And now I would hand to Professor Denise Leavesley, who is the principal of Green Templeton College.
Thank you very much, and thank you to you all. I'd particularly like to thank Imogen Malpas and Isra Hasnain for organizing today's event. I think it's really important that we continue the discussion within the college and beyond on the inequalities and discrimination which continues to exist within our society. Acknowledging the huge health disparities which have existed historically and continue to exist is really important. But it's not just acknowledging, it's doing something about it. And so I think that the ideas that we've been given from the speakers today as to how we actually address these issues and how we try to ensure that, you know, in 10, 20 years' time, we're not sitting here still talking about the problems. I've taken away so much of the rich discussion, and I'd like to thank all of the speakers, but there are just a couple of things I'd want to highlight. I think the whole issue of the hierarchy within the health systems, and we've heard about it from the UK perspective and from the US perspective, but we know it exists in other countries too. The fact that people of colour are not supported to flourish. There was a very interesting program on the BBC the other evening about Black nurses. I don't know if any of you saw it, about how Black nurses are dependents within the health system on Black nurses, but how they simply haven't been supported to get the promotions and the positions of influence that they really need and deserve. It was a fascinating program. And of course, all of us have been hit by the statistics of the disproportional impact of COVID. But I've also been interested in the role of professional bodies, associations and colleges. We don't discuss this very much, but they are bastions of the society, and getting them to change is quite difficult. And there's a hierarchy in professional associations, certainly within this country. One of the things that we've been discussing within Green Templeton College is whether there should be stronger professional associations for, say, care workers. We've talked a lot about the health system today, but we haven't talked about the associated care system. And if anything, the results in the health system in terms of the differential impact of COVID have been even more marked. I'm fascinated by the discussion on medical education, and I hope that we can empower students, and that's what we need to do. So I hope that we can listen better to students and respond to their interests to a greater extent than we have done. And then the overriding thing that I took away, that again is something we're discussing within the college, is that countering racism is not just the responsibility of Black people. That actually you're tired of doing it for us. I took that down. I think that's a really powerful message, that we have a responsibility to act ourselves and that you can't be passively anti-racist. And I think that message to go out to the whole community is really important. So a wonderful, rich discussion. Thank you to all 4 of our speakers. So thank you to Monica Vela, Adwoa Danso, Helena Hansen, and Adwoa Adeyemi. And thank you, Noon, our wonderful former president of our graduate common room here in Green Templeton College. Noon, thank you for chairing. Again, thank you to Imogen and Isra for organising today, and for my team of colleagues who've supported you behind the scenes. I look forward to us continuing this discussion, and I look forward to our 4 guests. I'm sorry I wasn't able to entertain you to a nice lunch in the college. Next time you come, I hope you'll be able to have a lunch in the college, but we look forward to engaging with you as we in Green Templeton try to play our little part towards countering these problems. Thank you.